on epidemiological research. So if you remember where we left off with at the end of our lecture on Tuesday, we were talking about the three primary types of epidemiological research design. That includes intervention or experimental studies, cohort studies, and case control studies. And we had begun talking about all the different potential ways in which there could be problems with the different research designs, some of them associated with all of the designs, like problems with participant dropout, and some of them more so connected with specific kinds of designs, like problems with choosing control groups for a case control study. And so we're continuing on for the next few minutes to talk about additional sources of error, and then we'll talk about how to create better studies with more validity. So first things first, one potential source of error that you would want to be very mindful of is one called selection bias. Selection bias is particularly relevant when you're engaging in an intervention or an experimental study. Selection bias is relative to that notion that you have to select randomized groups when you're creating your two groups for your experimental study. And unfortunately, there always runs the opportunity that you could work through separating participants into groups without being perfectly random. So for example, if I was trying to separate groups based upon a certain characteristic, let's say diagnosis with a certain disease, and I didn't pay attention to the fact that I had more females in one group rather than males, or that there was another factor that joined together the people in one group as being more similar than the group that was serving as the control group. Unfortunately, then, rather than the experimental intervention or the treatment being the effective part of my intervention, I'm getting results that are potentially due just to differences between the groups, differences based upon the other health condition or upon your gender, and not really differences connected to the treatment or the intervention that I'm running. So selection bias is relevant in the context of not being perfectly random when you're putting people into groups that need to be separated in a random way. Another really quick mention of another kind of bias, one bias we're mindful of is called sampling bias. That's when you're trying to draw inferences about the broader population based upon a specific sample that you draw. But unfortunately, there could be times where the sample that you draw isn't particularly representative of the entire population. You know, I like this graphic here in that there's a rainbow of colors and we're trying to draw an inference about everyone. But what if we only took those individuals inside that circle? We're only then considering more so red and yellow than we are all the other colors. And if you think about it in that kind of way with experimental research or really other kinds of research too, when you're drawing your sample based upon just 10 people, can we be sure that those 10 people are really fully representative of all other people? We work on lots of studies where we draw samples from college students because they're easy for researchers to access. You all are doing research for participation and extra credit points. But truth be told, how generalizable are findings for college students to absolutely everyone outside of college? I'm not so sure. So sampling bias is when the sample that you draw might not be fully representative of all the other participants you could be pulling from. And last but not least, we've already talked quite a bit about reporting or recall bias. That's the bias that happens when you ask people to remember what they've been exposed to or previous behaviors, and they just have a tendency to misremember or come up with things that didn't really happen or not be able to recall information at all. And so there are lots of biases when you present the potential for someone to recall something that took place in the past. So these are some of our biggest problems in the world of study design. So if those are problems, then it fits that we should probably have some recognition of potential methods we could use to address some of the problems, potentially other factors that could help validity if we're struggling to establish it in other kinds of ways. One factor that we discuss quite often is looking for strong associations. When you're looking for an association between a risk factor and a health condition, often it's the case that the stronger the association, the lesser chance we have that a confounding variable is present or that our results are just due to random variation, like we talked about at the end of class on Tuesday. We expect there to be a certain number of results due to chance, and we don't want our findings to be connected only to the opportunity of chance. And so we want our findings to be due to actual real things and not just sort of like random luck. And the stronger the association between two things, which is usually something that's pulled from our statistical work with our research and data, the more likely we can feel that what we found was really something worthwhile and not just something you would expect to happen at random. Another important factor that helps validity is what we call a dose-response relationship, and you can see that represented in the graphic on the screen. What I mean by a dose-response relationship is one where as each dose of a medicine or a treatment or an intervention is provided, an expected or matching outcome is observed. So think about this in terms of your taking of medication. If you were to take one Tylenol to reduce your pain, of course, we would see an association that would, for many of you, relieve some of your headache or whatever you might be feeling. If you were to take two Tylenols, then we might expect that the amount of relief would double. If you would take three Tylenols, then maybe the relief would triple. We know that with many of our medications, we have a pretty significant positive association that looks like a dose response. For each additional dose, you have the matching and expected response. For most medications and all other kinds of treatments, this exists up to a certain level, and then there's a point at which there's too much of the medicine that could unfortunately be leading to other kinds of damages and negative effects. But you can see in the graphic on the right, it's representing the relationship between number of sessions of psychotherapy and how people improved in terms of their sort of overall ratings of improvement based upon whatever the case might have been for the psychotherapy. And you can see here a pretty consistent dose-response relationship up until about 26 sessions, such that for each additional session, you see a matching and expected outcome in terms of the percent of improvement. So that would mean if you went to 2 sessions, you would improve 20%. If you went to 8, you might see 40%, 26 sessions, and you're all the way up to 80% improved. But as you can see, after about 26 sessions, the line tends to become a little bit less drastic in the improvement and really evens out, such that 52 sessions, doubling that, really doesn't lead to that much of an improvement. But we can see up until about 26 sessions that there is a consistent dose-response relationship. So having dose-response relationships does help establish our validity because it just makes sort of common sense that as we increase treatment or a medicine, we would see a matching response. Thirdly, we work hard to have large study populations because the larger the study population, the less of the opportunity for sampling bias, the less of an opportunity for selection bias, and also the less of an opportunity for other kinds of biases that could be present just from statistical random variation. So we work really hard when we're engaging in clinical trials to test medicines, especially to have large numbers of people take part. You might remember the Nurses' Health Study had close to 120,000 nurses, so that when we have findings, we can feel confident that we can generalize them to the general population because our sample was big enough to capture a representative look at more than just maybe 10 people. Next are consistent results from other studies. Now, I'm not here to say that we couldn't have really innovative, brand new studies that find some sort of research finding that isn't something we haven't seen before. Of course, that happens. But in many cases, when we have results that are sort of in an expected direction, they're much easier to feel comfortable with the validity that they offer than one that's completely different than every other study that's been done before. A study that's different would probably cause people to reinvestigate and run it again to see if in the same conditions that study could be replicated. But more often than not, if we can find consistent results, then we feel a bit more comfortable that the study was a valid one. And last but not least, a high relative risk or odds ratio. Keep in mind that an odds ratio is looking at the sort of ratio between those who are exposed and get a disease over those who are never exposed and end up getting the disease to understand really what are the odds of developing a disease after an exposure. And what we've come to find is that if an odds ratio is relatively low, we have a pretty high opportunity for just chance to be leading to the risk and the odds that we see presented. And it becomes not that telling of a result if the odds are just an extra 1 rather than 14 times more likely, as we saw with the lung cancer example in class on Tuesday. So usually the higher the odds ratio, higher the relative risk, the more comfortable we can feel that our study is a valid one. So one quick example that I wanted to provide relative to this question of investigating the Just making sure I'm still recording. Perfecto. One study that really helps elaborate some of these problems comes in the world of hormone replacement therapies. This is a particular area of research where for a really long time, we had a lot of conflict between findings. Particularly, we had a number of studies that were showing that there was a consistent positive relationship between hormone replacement therapy and diagnosis with breast cancer. In fact, there was a very, very large study that was conducted in the UK, large in the sense of a large number of participants taking part, who did, in fact, argue that there was a significant relationship between hormone replacement and breast cancer. Unfortunately, even though that study was really big, it was an observational study. And so there were a number of years where women chose not to get hormone replacement because they thought it would cause breast cancer. But that was based solely on studies that were just observing potential relationships. We know that clinical trials and experimental research in really defined, well-organized conditions with a control group and an experimental group are the gold standard. But none of these had really been conducted with hormone replacement therapy. So we move forward now from our original Million Women study to 2015, when we see a number of experimental studies looking at hormone replacement therapy, and ultimately the relationship falls apart. We don't see that HRT is causing breast cancer. So really, when we started to investigate some of the reasons behind the cohort study findings, we found that there were a large number of confounding factors. Ultimately, one of the most important was that women who made the choice to get hormone replacement therapy ultimately were healthier women that ended up staying healthier even without any sort of therapy taking place. And so some of the relationships that were emerging apart from breast cancer just sort of fell apart when you looked at who was taking part and signing up to be in the cohort group that was studied. And so ultimately, under the confined restraints of an experimental study, we found that that relationship didn't quite hold as true as what we had once thought. So that's just a good example of something from the real world of real problems and real research that shows how important it is to be mindful of the potential errors in your study design. So I want to end our conversation for the next few minutes on Chapter 6, discussing some of the biggest problems we've had in being ethical researchers, particularly in the context of biomedical and epidemiological research. Up until, the 1980s, really, we had a pretty nasty track record in terms of engaging in some research that wasn't particularly ethical or mindful of participant rights. That research, unfortunately, stretches back to the 1940s and moving forward through, Vietnam, and some really horrible experiments that were done on humans. Particularly in the context of World War II, we saw a large number of experiments on prisoners and on children who were denied anesthesia, children and prisoners who ended up dying or were disabled or disfigured based upon really experimental processes of physicians at that time. And so, of course, people who were, in some of our encampments were put under the guise of being participants in research studies that they never, of course, gave any consent to. You would find some really sad stories, the graphic on the right, about children who were purposefully denied food to study the results of malnutrition on health. It's just a horrible, horrible research context. Thankfully, the Nuremberg medical trials in the mid-1940s and the resulting Nuremberg Code, which drives really the ethical principles of all research moving forward, was focused largely on ensuring that, from then on, all participants were giving consent to engage in research. Ultimately, this principle of informed consent was implemented on an international level following the Nuremberg medical trials and our investigation of what went on with Nazi medical research. So it was a really important changing point in our thoughts about how to engage in research from an ethical standpoint. Move forward sometime, and we really, unfortunately, this example doesn't draw upon some great improvement in that light with what went on with the Nuremberg Code. Relative to the Tuskegee syphilis studies, which I'm sure many of you have heard of, they've been commonly discussed, probably in more places than an epidemiology class. But for those of you who don't know, these were a series of studies that were conducted between 1932 and 1972. So this is a long longitudinal study that was observing about 400 African American men who were diagnosed with syphilis. And the purpose of the study, unfortunately, the men didn't know this, was to observe the effects of the disease when men went untreated. Now, that wouldn't be particularly harmful if the men understood at the beginning that that was the premise, and if there was no treatment available. But unfortunately, throughout the course of this time, there was, in fact, completely efficacious treatment to be given to these men with syphilis. However, the men were denied treatment who were engaged in this research study. They had no idea that they could have been treated. The researchers withheld the treatment from them so they could just study the natural course and progression of syphilis on these men. The men were never informed of the nature of the experiment. More than 100 ended up dying as a result of the medication for treatment being withheld from them. And so it's just another horrible mark on research and epidemiological history when you look at the unfortunate acts of the researchers who were, by premise, aiming to, I think, with good intent, study treatments for this disease, but did so in a really horrible and unethical way by not informing the men and by withholding the treatment. I have another story that I'd like to share with you, and this one wasn't included in your textbook reading. So just to point out, this is one that'll come just from me and not from reading, but I feel like it's a really useful, meaningful integration when we're talking about questions of medical ethics. This one comes from the story of a woman named Henrietta Lacks. You might have heard of Henrietta Lacks in the last few years. There was a book published on her story called The Immortal Life of Henrietta Lacks. If you'd like to read it, it's a great book. I have a copy in my office. You could come rent. Oprah took on the story of Henrietta Lacks and actually created a major feature film. And the story was more so relative to the journalist who uncovered what was going on with Henrietta and then investigated some of that with her family. It's a really good movie if you'd like to check that out too. But for those of you who don't know the story of Henrietta Lacks, I thought I would integrate this nice short few-minute clip that discusses why she was such an important person in the history of biomedical research and ultimately why it's a worthwhile story when we're talking about ethical problems in epidemiological research. So let's check this one out. The video here y'all should play, but I think what I'm going to do is pop off my screen share and head over to YouTube just to make sure that y'all get the video. All right, let me share my screen here. Got all the right buttons clicked. All right, check out this quick story with me.
Some of the most important advancements in modern medical research can ultimately be traced back to a Black woman who worked on a tobacco farm before World War II. Her name was Henrietta Lacks. In February 1951, Lacks was diagnosed with an aggressive form of cervical cancer at the Johns Hopkins Hospital. Unbeknownst to her, a sample of her cells was sent to a tissue lab. A cell biologist isolated and then multiplied it.
As it turned out, the cells did not die, as would normally be the case. And in fact, they were doubling at this phenomenal rate. They would just keep replicating.
Although these weren't the first human cells to be grown in a lab, this was the first time they survived more than a few days. This huge medical breakthrough allowed researchers to conduct experiments on human cells outside of the body. The cells were given the name HeLa, a combination of the first two letters of Henrietta Lacks' first and last names. Although they carry her name, Lacks, who passed away at the young age of 31, would never know that her cells had been extracted for scientific research. Lacks' family members only learned that her cells had been harvested 2 decades after her death. A Rolling Stone journalist contacted them and revealed that Lacks' cells had been duplicated and then used for research by countless scientists. The article called the work a critical tool in medical research. While HeLa cells have played a crucial role in scientific advancement, the fact that Lacks herself never consented to the research means that her cells were used unethically. What's more, her case was part of a long tradition of the use of African American bodies without their consent for medical and scientific research, dating back to slavery and including the infamous Tuskegee syphilis study.
It was part of a culture of not respecting the core humanity of Black folk and how they were being treated either by medical researchers or even by physicians.
Despite the ethical debate around the harvesting of lac cells, scientists have continued to use the immortal HeLa cell line all over the world. Research involving polio vaccines, chemotherapy, HIV/AIDS, cloning, and IVF have all benefited from the HeLa cell line.
All right, I'm going to stop sharing that and head back over to our PowerPoint slides. So I think one of the important things to keep in mind with a story like Henrietta's is that, you know, despite the fact that there have obviously been a significant amount of biomedical findings from the use of HeLa cells, as you saw at the end of the video, ranging from polio vaccines all the way to IVF treatments. And those obviously saved the lives of many, many people. The beginning of that research comes from the unethical process of taking something from a woman who never gave her permission or consent, which is an uncomfortable feeling. So there's a consistent debate upon the story of Henrietta in terms of the health of Henrietta and her rights to have a say on what was done with her body and her cells following her death, versus the common good of how many people were, you know, saved, how many lives were saved using HeLa cells, and how much research has resulted from use of these immortal cells that don't seem to die and continue to replicate. So it's just another interesting example that fits in our conversation of bioethics. A short follow-up to this story, which you can learn about on your own if you'd like. Thankfully, Henrietta's family, after learning about what had taken place with their mother, did quite a bit of lobbying for their own behalf. And now her family sits on the board that makes decisions on what researchers get to make use of HeLa cells. So they do have some responsibilities and rights in the future research with HeLa cells. Unfortunately, however, they haven't seen much of a monetary compensation when thinking about the amount of biomedical research economy that has come from all of the great contributions connected to Henrietta cells. And so they haven't really seen much monetary kickback, but they have been recognized in having some control over the research that results from her cells. So one really quick final example, and then I want to talk a little bit about clinical research and drug trials. This is an unfortunate one that actually bumps us forward in time a bit. It's easy to look back and think about this unethical treatment in the 1960s and 70s. But this story actually comes from the 90s, so much more recent. This was actually connected to a researcher who was working at a university in South Africa, who had started to make some claims that one of the most effective treatments for advanced stage breast cancer included high-dose chemotherapy that was followed directly by a bone marrow transplantation in women whose cancer had spread to their lymph nodes. And this was something that was really groundbreaking in terms of the world of oncology and breast cancer research. But it was so groundbreaking and so different, and the results were so overstated in a way that some researchers thought that they would check in on some of the processes of this particular scholar. They traveled to South Africa and started looking at patient files and protocols. And as we've talked about, in normal clinical trials, people are randomly assigned to experimental groups or a control group. But for this particular Dr. Bozwoda studies, they couldn't find any records showing that there was any control group. There was any group that could be compared against the experimental group to argue that the differences were connected to the experiment and not just, an artifact of that particular group. And then also they found that a large number of the results had actually been completely fabricated, total lie. Even worse, a lot of the women who were studied for this particular research had never been offered a full understanding of what consent meant, what the treatment looked like. Many of these women couldn't read, and so consent was engaged with in a written form, and without being able to read a consent form, they were being subjected to treatment that they didn't understand. And so the estimation of 4,000 to 9,000 women who received an experimental procedure due to falsified results, and potentially the side effects of engaging in that. It's a little crazy when you think about it. So I encourage any of you who yourself or family members are thinking about an experimental treatment for a chronic health condition to be really mindful of investigating the research behind that, so that you very clearly understand that that research had its limitations and that you know what you're getting yourself into, especially, when you don't necessarily know the full story of the research process behind the finding. So last but not least, I want to spend just a few slides on some ethical solutions. I guess we could call them solutions, but other potential ways in which we're addressing some of these ethical problems. We have engaged in some new rules for studies that force us all to make use of informed consent. I'll tell you, though, that there are still some problems in terms of literacy levels. Sometimes informed consent forms can really be filled with jargon and medical terminology. And if a population has difficulty understanding those things or reading them, then they might not really understand what they're getting themselves into. When I work in low resource audiences, I always have someone accompanying me who takes the time to explain the informed consent form verbally to participants to ensure that if they can't read it, they can understand it with just an explanation. We also seen the development of what we call institutional review boards. There's even one here at Ball State. Most organizations, including universities who engage in research with human subjects, have an institutional review board that will review the applications of potential researchers and approve or deny their research before it can take place, based upon whether or not they're engaging in research in an ethical way. And so when any researcher here at Ball State wants to engage in a study, they have to get IRB approval, which means they have to send a long application to the IRB and get their approval that their research design is ethical before they start with their research. We also spent quite a bit of time trying to regulate medical providers who, in many cases, have conflicts of interest with pharmaceutical or medical device or treatment companies who could potentially profit by providing those treatments or pharmaceuticals to their patients. This was a very big problem quite some time. We were finding doctors who were being paid to advertise and promote certain drugs in terms of the research that the companies were doing or that the physician was doing, essentially to provide some sort of kickback to the physician or kickback to the researcher in terms of who was prescribing these treatments to the public and recruiting people for clinical trials. And so obviously there's some ethical problems when someone is recruiting and helping people gain participants, but potentially not being the most honest about side effects or risks if they know that they'll get a monetary kickback for doing so. And so your bioethics briefing discussion board was asking you to think about the potential conflicts of interest present, and if you are in agreement with that, because ultimately, we're going to have conflicts of interest in many cases. And as long as medical research is advanced, do we really care that much that doctors get some money for helping people along into these studies or these treatments? Or do we feel much more uncomfortable that a physician or a researcher is going to get a monetary kickback if they're researching something that a pharmaceutical company could give them some money for doing? So there are definitely both sides of an argument, and I look forward to seeing your responses on the discussion board to get a sense of where we were situated with how we felt about those conflicts of interest. So my last slide in the conversation of chapter 6 was speaking directly to this conflict of interest question in drug trials. And I'll tell you, some of this conversation also isn't in your textbook, but I just think it's really important information for you to know about. So I think it's useful for you to keep in mind. I teach a consumer health class and I talk a bit about clinical trials. That drug companies are required, of course, to conduct really rigorous randomized controlled trials before drugs can be approved. So, of course, we have high expectations that before a drug finds its way to market, a medicine for any condition, it has been tried through the clinical trial system. And in fact, many of our drugs today have, of course, made it through that process. But I think there's something to be said more about the research design of many of those clinical trials, particularly who serves as the participants. And so I'm going to actually talk more about that in just a second. Also noted here, we know that there are lots of drugs that have harmful side effects that aren't found until long after a drug is approved. Of course, most of our clinical trials attend to potential side effects that could happen not immediately after a drug is taken, but we also aren't going to wait 30 or 40 years worth of clinical trials to push a drug through to market. And so there is always the potential that we could find side effects for a drug much long after it was approved. There's also some evidence that drug companies sometimes suppress negative findings, and that's something that's discussed in this video. I'm not going to play the YouTube for you from this speaker, but I encourage you to check it out on your own, where this medical researcher and bioethicist is talking about how hard it is to get certain studies about certain treatments or findings published. And we know that if a study isn't published, it's unlikely that the public is going to hear about it, that a practitioner is going to pay attention to the finding in that study. Really, the findings that are used for practice are those that come from publication. But we found that many of our publication outlets will only publish research that has a positive finding. What I mean by positive is that it is in line with the hypothesis suggested by the researcher. If a researcher thinks something's going to happen and then they find that it doesn't, they're very unlikely to get published. So if they have a treatment and they put people through trials and experiments and it doesn't work, they're probably not going to get that study published. But there's a lot of profound information that can come from knowing what didn't work. And sometimes you can learn more about a drug or a treatment from what didn't work than the one thing that did. And so it's a real deficit that we have a system that only features articles and talks about research that is positive research, that doesn't highlight negative findings. But it's important for you to keep in mind, and as I should hope that you all will do, that you can access clinical trial information through a public database. It's now perfectly accessible to the general public. If you head over to clinicaltrials.gov, you can see the research that's available on the clinical trials that are present with any drug that you currently take. I have students do this for an assignment in my consumer health class. And so I have them take a drug they currently or have taken, and they have to do a little research to figure out what the clinical trial process looked like to get that drug through to approval. And some of them have found some really interesting, sort of scary things when it comes to how those drugs were tested before they were marketed. But I encourage you to make use of that tool. Now, one quick thing I want to go back to, and I'm going to actually play you a very short clip from my very favorite podcast, Freakonomics, relative to this question of who is used as the research participants in many of our clinical trials for pharmaceuticals. I had no idea that the pharmaceuticals that we use aren't always tested on populations that are really that representative of the people that they're prescribed for, until I came across sort of randomly this episode of Freakonomics and started researching it a bit more, and was very surprised by some of the discussions that were present and some of the real unfortunate biases that are put forward in our clinical trial process, particularly thinking about gender biases, which I think you'll pick up on in this short clip from Freakonomics. So I'm going to stop sharing here and I'm going to head over to my Freakonomics page and have you listen to just a few minutes of this podcast with me. And I think you'll be pretty shocked when you hear about this process. So let's listen.
In the mid-20th century, an exciting new drug hit the market.
It's a small molecule that was produced in West Germany in the late 50s and early 60s.
It was a sedative, but not a barbiturate, so it wasn't addictive, didn't clash with alcohol or other drugs, and, according to its manufacturer, was entirely safe. They based this claim on the fact that no matter how much of it they fed the lab rats, the rats did not die. Once this new sleeping pill was made available, doctors discovered it did more than help people sleep.
It would combat, for pregnant women, morning sickness.
And so, pregnant women all over the world were given the drug. It was called thalidomide.
The problem was the thalidomide would actually cross the placenta and impact the baby, and it would cause a whole series of malformations and probably a lot of fetal death.
Fetal deaths were thought to number at least 10,000. Among the babies who survived, there were serious birth defects.
Children that survived were deaf and blind, had a number of disabilities. They had shortened or lacked limbs.
Babies born with horribly malformed limbs, with missing or malfunctioning organs, because of the putatively super safe drug their mothers took to prevent morning sickness. Thalidomide was on the market for roughly 5 years before it was banned. Its German manufacturer, Chemie Grunenthal, first denied the disastrous side effects before ultimately accepting blame. The history of medicine is full of tragic missteps, but thalidomide, coming as it did during a boom in global mass media, made more noise than most.
The problem of tighter controls to prevent the distribution of dangerous drugs, such as thalidomide, is a matter of concern to the president at his news conference.
Concern over the tragic effects of the new sedative thalidomide prompts President Kennedy...
Already, more than 7,000 children have been born with some or all of their arms and legs missing.
Every doctor, every hospital, every nurse have been notified.
Although a few million thalidomide tablets had been distributed to doctors in the United States for trial use, it was never approved for sale here. That was thanks to a doctor at the Food and Drug Administration named Frances Oldham Kelsey. She did not believe that the application from the American distributor offered complete and compelling evidence of the drug's safety. President Kennedy later hailed Dr. Kelsey as a hero.
The alert work of our Food and Drug Administration, and particularly Dr. Frances Kelsey, prevented this particular drug from being distributed commercially in this country.
Even though the U.S. was an outlier in blocking thalidomide, the disaster had a number of lasting effects on American drug regulation. For one, the FDA established much more stringent rules for drug approval. It also rewrote the rules on what kind of people should be included in clinical trials.
Because of the effects on young women and on the fetus, it suggested that women shouldn't be included in clinical trials because of the potential adverse events to the fetus.
Meaning women were summarily excluded from early clinical trials for new drugs. On one level, this might make sense. It's a protective impulse. But this impulse had a downside.
The study of women in general became part of the collateral damage of that pregnancy conversation. So there certainly are young women who are not pregnant who could be included in clinical trials, and women in general could be included in clinical trials to really understand some of the effects of drugs on their own health. And they were labeled as broadly vulnerable because of the potential to become pregnant. And I think that was part of a very rapid response to a very, very visible tragedy.
We see this all the time. Something terrible happens, and we rush to introduce laws or regulations or just mores that respond to the terrible thing, but often wind up overcorrecting. Think about the 3 Mile Island nuclear reactor accident in 1979. No one was killed, and the lasting health and environmental effects were negligible. But it was so frightening that it essentially killed off the nuclear power expansion in the U.S. Even as other countries embraced nuclear as a relatively clean and safe way to make electricity, often using American technology, by the way, the U.S. retreated. What'd we do instead? We burned more and more coal to make electricity. Now, from an environmental and health perspective, coal is almost indisputably worse than nuclear, but that's where the correction took us. That's where the fear took us. And the fear of another thalidomide took us to exclude most women from early-stage drug trials and also to underrepresent women for a time in phase 2 and 3 trials, even if the drug's market included women. And as you'll hear today on Freakonomics Radio, that had some severe unintended consequences.
It's just heartbreaking to know that so many women had to wake up in the morning, and they still got up, but they went out and drove into the side of a mailbox because we didn't have sex as one of the variables that we would study.
Also, when the only thing worse than being excluded from a medical trial was being included.
So I'm going to stop it there and move back over to our lecture slides, and then I'll chat a little bit about what you just heard if you didn't catch all of it. So hold tight. Here we go. me share my screen again. All right, so we're back to our PowerPoint. So the general story goes, if you didn't catch the entirety of that we had a drug that was prescribed, it's some time ago in the 1960s, found to be pretty effective for sleep issues, but also for morning sickness. And so it was given to a number of pregnant women. Unfortunately, led to a significant number of birth defects, malformed children, some problems with children who are just missing organs and limbs, which is very scary. And because of that, the drug was taken off of the market. And thankfully, it was never prescribed in the United States because of our regulations. But what it did do is really limit and over-regulate in some ways how clinical trials for new drugs were performed all over the world, and especially in the US, such that early stage clinical trials for most medications do not include women at all, under the potential risk that a woman could be pregnant and doesn't know it. So women of the potential age to get pregnant, which is a really long span in a woman's life, are present an extra risk if they're taking an experimental medication, and we don't know if it has a risk to the child. And so women aren't even asked to take part in phase 1 trials and are much more limited than men in phase 2 and phase 3 trials before a drug is brought to market. What that does, unfortunately, is put a lot of drugs on the market that were never studied in the context of the female biology. The example that was mentioned at the very end of that podcast clip, where someone was driving into the side of a building or driving off a bridge, speaks to one of our most commonly prescribed medications here in the United States. A medication some of you might have heard of called Ambien or Zolpidem. Ambien is actually a medicine that was only tried in phase 1 with men and was very limited in its further stage trials with women, very few. And ultimately, we were finding after prescription, there were a number of women who were having instances of falling asleep at the wheel in the morning after they had taken Zolpidem that night. And we found that the pharmaceutical itself metabolizes different in women, such that the effects will stay much longer in a woman than they will in a man. And so the effect was just felt more so in the morning, and women thought they were fine, and unfortunately they weren't. We would have known that if we would have had more women in the clinical trial process, but thanks to thalidomide and the changes to clinical trials, we just don't have many women in our clinical trial systems for lots of drugs. So ultimately, I just think it's an interesting story of how we have to be mindful of who we represent in our trials and how much trust we give in some of the experimental medications that we see find their way to market. It's encouraging for you all to just be really mindful of the medicines that you take. I think, friends, that's the end of my chapter 6 conversation. Now, I know I don't have a ton of time, but chapter 8 is one that I can make my way through pretty quickly. And that's talking about the uses and ways in which we get data in the world of public health. I don't think I have to elaborate too much on the wide variety of ways that we use data as public health practitioners. Of course, we've already talked about how we use it to assess the health of a community. It becomes the raw material that we gather when we're engaging in research with the population. Data allows us to identify special risk groups who might be presenting an exceptionally high rate of risk for a particular health condition. It allows us to keep track of where new threats are emerging within communities. I use data to evaluate the success of the programs that I run. So if there's a problem and I run a program to address it, I evaluate the program's success and then make arguments about whether that program should be ran again or not based upon the data I've gathered. Last but not least, data can be really important to preparing budgets so that you can make arguments where resources should be allocated to address public health problems. So many of you probably remember the coronavirus dashboard that the Indiana State Department of Health had crafted. Most of our media outlets were showing graphics and screenshots of the dashboard as they were talking about COVID. Of course, this represents some very basic numbers with the COVID pandemic. We have the count of cases, we have hospital admissions and deaths, and a look at the county by county rates at a particular amount of time. What a lot of people don't realize is that was just a small picture of the actual amount of data we were gathering as COVID was emerging and spreading. You can see here it ranges from hospitalization to vaccination information and even very specific information about how many cases we've had getting each dose of the vaccine. We have county by county data on how many vaccines have been given. We have data on the variants that are present, on the average number of cases per vaccination status. I mean, we have numbers and data for so much in the world of COVID. And so it's just useful for you to keep in mind that there's often a lot more data available than what we sometimes see as the public consuming information from the media. Also, I thought I'd elaborate to you how this can be even closer than what you might really understand or have thought about before. Here at Ball State, our Office of Health Promotion and Advocacy and our health clinic actually collect data frequently from students on a variety of health behaviors and health attitudes and things relative to both physical and mental health. We have a mandate from the federal government that we frequently conduct these kinds of assessments through the National College Health Assessment Program. And so our office will frequently survey students to learn about what they're doing and report that data back up to people who allocate policies and people who decide policies and allocate resources for programs and colleges. So you can see here just a picture of Ball State's campus. This comes from our spring 2019 data, so just a few years old. I didn't have access to any of the newer data at this time, but you can see some interesting findings from this data relative to alcohol use and the composition of that spread across both males and females, as well as marijuana use. Interestingly, we have more females who've never used than males, which is, I think, an interesting story to be told from the data. You can see relative to mental health outcomes, feelings of hopelessness or being exhausted or lonely. We are a campus that has particularly high rates of mental health issues, and it would be this data that would serve as the evidence we need to argue for more mental health programs and resources on our campus, which is definitely something that we will return to later in the semester. So data becomes important for all of you in terms of the resources and the programs that are aimed to address health problems, even on this campus. Indiana is a state that's actually one that has a lot of data available. We really don't struggle much with what we have. Our problem is that it's very spread across different entities, and any of those entities can be very proprietary over the data they have available. So we have more issues with how the data is shared and ensuring that all our public health practitioners who have the data know how to use it, know how to analyze it, and use it in arguments to have additional programming within communities. So last week, Governor Holcomb announced this big initiative to begin what's called a digital transformation project that's going to create a centralized platform for really any entity connected to public health in the state to store data that could be publicly shared with all other kinds of entities in the state. At current, we don't have a whole lot of ability to access data relative to what's going on in communities around us. Nearly 80% of our health departments say they need support in analyzing data. So this initiative is going to be a great one to help make more data available for the people who need it to ensure that their communities are kept safe. So it was really one that is making use of the money in the public health world to engage in a project that will benefit local health departments. So where do we get the data that we use? Well, there are a variety of ways. We'll talk about sort of the biggest and broadest first, and then get into the more specific. Of course, local records are a really important source of data in the world of public health, ranging from birth and death certificates to our notifiable disease reports and other vital statistics that we gain from our population. We'll talk in a minute about some problems with these local record methods, but in general, they are pretty solid ways in which we can gather the health of a community through births and deaths and causes of death. Information that is gathered, I should mention, has a couple of different ways of being transmitted, but the general systematic method of transmission is that data that's gained at the county level is first transmitted to the state health department, and then that information is sent up from states to the National Center for Health Statistics, which is our national center that really keeps track of all of the data they receive from public health departments across the country. There are some specific computer systems that are set up for specific kinds of records. So I know some of you in the class are interested in the work of women's health and maternal health. And there's a specific system as part of the National Center for Health Statistics that actually is used to link all of our vital records of infants, because infant mortality is such an important public health problem. And so that system is called SetNet. And all of the information that's gathered in newborn and prenatal screenings is actually sent into the SetNet program and transmitted to national offices. So there are some systems that are there to gather information on specific problems. But as I mentioned, I think there are some things to be discussed relative to potential sources of error in those records that we have available. Of course, this would be a place for some discussion in class. So we don't have much room for that in a recorded lecture. So just to give you some hints here, of course, in birth and death records, we're relying so much on the honest, accurate understanding of what happened with a patient, especially with the death record, relative to the person who completes that record. And we're hoping that that person is really honest and understands the real cause of death as they're putting that onto a death record. So there's the opportunity for some bias and some misrepresentation if the information there isn't accurate. Of course, when we think about other kinds of records that are important for us, things like spontaneous fetal deaths or deaths during pregnancy, we have cases of women who miscarry and never report that to a physician. And in those cases, we obviously wouldn't have a full and broad understanding of spontaneous fetal death without knowing about those cases that were never reported. The same holds true for abortion. If you are receiving an abortion from a non-federally certified health clinic, that information might not be shared where it needs to be shared. And so there are obvious problems in many of our common records that are collected at different points in life. These aren't substantial, but they are worthy of being noted and considered when you're relying on just a death record or just a birth record to give you all the information you need about a population. So just a quick word on the reporting system that's used. The system has a cool acronym. It's called ESSENCE. That stands for the Electronic Surveillance System for the Early Notification of Community-Based Epidemics. This is a system that every emergency department across the state is required by a state law to use in reporting potential cases of an epidemic present within someone who's making a visit to the emergency department. So all of those notifiable diseases are actually reported through the ESSENCE system to the state health department. And then in many cases, the state will send that data up the pipeline to the CDC. So, of course, if there's something going on, we observe the person and we validate it. If it's an expected or unusual case, we assess if it's a public health threat. And if it meets those categorizations, then we will send it up into the ESSENCE system. The cool thing about ESSENCE is that if enough people and enough departments across the state are reporting the same case, it'll actually send an automatic alert out to our state and local public health departments that the emergency departments are reporting something unexpected, but in a variety of different places, and we should be alerting ourselves to it. So it's kind of an automated system for keeping a tab on what's going on across the state when it comes to early notification of epidemics. So ESSENCE is a really important system. We also have CHIRP, which is our electronic immunization registry program for kids and all Hoosiers that keeps track of your vaccinations across your lifespan. So that if you're going to a doctor in your 40s, they could still have record of shots that you've gotten all the way back to when you were a child, which is really important so that vaccinations are done under schedule. Last but not least, the Indiana State Department of Health actually has the very first in the country health information exchange. What an exchange is a system that actually collects and shares data from hospitals about patients to those in the world of public health. It doesn't collect all community members, it just collects private health information from hospitals. Now, 20 million sounds like a lot, but it isn't a full representation of the entire number of citizens in Indiana. And so while we're the first to have an exchange where public health professionals can access information on patient populations, we are, of course, the first and one of the largest and still continuing to grow, which is a really great success in the world of public health and biostatistics in the state of Indiana. So it's something we're really prideful of, is having the first state-based exchange in the country. So other systems that are used to give us data in the world of public health, the census is super important. As most of you already know, the census is mandated by the Constitution. It assesses really important demographics like age and sex and race and ethnicity, those become the denominator for many of our calculations for at-risk populations in the world of public health. The census is conducted every 10 years, and we know that it's important because it determines the political composition of Congress and that there's congressional districts across the US matched to what we find in the census. You may or may not know that there's actually a shorter version of the census that's conducted between the 10-year time span, more ongoing. That's called the American Community Survey. It assesses things like education, housing, health insurance status, on a more frequent basis. So public health scholars love the ACS because it gives us data that we don't have to wait 10 years for. But it's worthy of noting with this census that unfortunately we still don't have great response rates across all counties in the US. 60% is considered pretty good, but it's still not everybody. So the census is a great tool, but also one that shouldn't be overstated in terms of its representation, especially in some parts of the country like Texas, where there just aren't a lot of people taking the census. As a quick mention, as we finish things up in the next few slides, relative to surveys that are unique just to the world of public health, there are a lot of these, and I'm not going to expect you for the exam to know the unique differences of all of them, but I'm going to mention two because they are so important. One of them is called the National Health and Nutrition Examination Survey, or NHANES. That survey is really important to those in public health, especially those who study nutrition, because it combines both a written survey as well as a physical exam. So NHANES surveyors go out to clinics and hospitals across the country and actually gather people who are visiting these locations and combines the survey about their risk factors and their behaviors with an actual physical exam of the person. So it really allows a much more specific assessment of the individual than just like you recalling things or making self-reported judgments of your weight or your blood pressure. It actually has a physical exam unit. Another important survey that I use often is called BRFIS. That's a fun abbreviation. It's the Behavioral Risk Factor Surveillance Survey. This is a state-by-state test. The results come in from each state and they're transmitted up to the National Center for Health Statistics. It assesses all kinds of behavioral risk factors. It really tries to narrow in to all of the things you're doing throughout your day that could have any potential of causing a health condition. The only deficit of the behavioral risk factor survey, in my opinion, is that it's telephone-based. And as you all know, telephone-based surveys can be really easy to deny, especially with do not call lists. So we sometimes argue about the representativeness of BRFIS, but generally it is a pretty strong assessment that many in the world of health behavior use to frame their research studies. You'll see I have a link here in this slide to a video about NHANES, just if you want to see what it looks like for this examination to take place in a clinic or a hospital. So of course, our end, just like our conversation of research designs and studies, is to just be really critical of the accuracy and availability of the data we have. Data collection is an imperfect process. It really is. Information technology is really helpful to increasing our accuracy, though, and the availability of our surveys. I used to run out and conduct written surveys, pen and paper surveys that, people could mismark or get lost in any kind of way. And now I run all my surveys with a tablet so that I don't have to worry about whether my data is finding its way to the computer. It's directly inputted, which is really helpful. The census is the most accurate, but as I've mentioned to you, there still are overcounts and undercounts and misrepresentations. You can see in the graphic here, especially for particular racial and ethnic groups, we find over and undercounts to be really problematic. We have a pretty big over-reliance of white populations in the census and a really big underrepresentation. You can see a massive sort of orange/brown graphic here for our Hispanic population who are really mistrustful of these kinds of assessment processes, and so they choose not to participate. And so that's problematic in terms of public health research when you have a huge racial or ethnic group that's being very misrepresented by the census. But public health informatics has improved the accessibility of that information. Public health workers can exchange it openly. And so we're definitely getting better in our data collection processes, but there are still some things to be mindful of. So last but not least is your participation activity for class next week. So I was going to have you on your phone or your computer, whatever you have accessible, head over to a very specific website that I'm actually going to show you in just about a minute called Indiana Indicators. Indiana Indicators is one of those health information exchange websites. It's a collaborative public health data source where a bunch of researchers and public health professionals have gathered their data together and made it accessible to the public. So it uses data from our BRFIS study. It uses census data, and it tabulates it into this really easy to access dashboard that even you will be able to use to assess the health of your community. So as I'm going to show you in a second, you're going to click on the dashboards option in the tab bar. You're going to put in your home county in the search tool. If you're not from Indiana, you can use Delaware County. So if you're a non-Indiana resident, just put in Muncie's County, which is Delaware. Then I'm going to ask you to select 3 health topics or areas, which you'll see in a second, and record your county's specific rate, which I'll show you, as well as any changes noted by the red or green arrow next to the number. Like, is that number getting better from one assessment to the next, or are we getting worse with that health issue from one year to the next? So all I need is your 3 health topics and areas and whether or not we're getting better or worse on a sheet of paper, typed or handwritten. And whenever you come back next week, Tuesday or Thursday, you'll bring that with you to class. So just so you can see the Indiana Indicators website really quickly, I'm going to share that one with you. So we'll end with this quick look. This is the Indiana Indicators website. And so what you're going to do is go up to this section called Dashboards right at the top of the screen and click it. On this next section, it's super simple to use where it says type a geography name. You're going to put in the name of your home county. Or if you're not from Indiana, you can choose Delaware County. My home county is actually Benton County, so that's what I'm going to put in. And then it'll pop up a little option here with the county name and you click on it. Sometimes because of the amount of data it's pulling, it might take a second, but then you're going to be given lots and lots of markers of health conditions, health issues, risk factors, you name it. So for example, I can see that new cases of cancer per 100,000 in the population are 503 cases. I can see that new female breast cancer cases per 100,000 is 113 cases, right? Lung cancer deaths, we don't have any and no % change. Mammography screening, we only see 45% of women in the county getting a screening for mammography. So first you'll want to pick your health issues. Now look here, you can choose cancer, chronic disease, community health outcomes, disease prevention, immunizations, you name it. I'll scroll a little bit, mental health, lots of things. Your goal is to just choose 3 of these. I want you to name which one you choose. So you would put new cancer cases per 100,000. Then I'm going to have you note the specific rate, which is this number, 503.9. And then the % change. So is it getting better or worse? And this tells us, because it's in red, right, that we are getting more cases of cancer than what we had in previous years. In fact, almost a 20% change since the previous assessment, which is a bad thing. And that's why it's in red. So pick 3 of these health outcomes, capture the information in the box with the rate and the change, put it on a piece of paper, type it or handwrite it, and that's what you'll bring with you to class next week. So I think that's it, my friends. I've taken up about an hour and I think 11 minutes of your time. I hope y'all have a really nice weekend. Let me know if I can help as you're getting ready for the exam next week. I will see some of you in the review session on Tuesday. And for others of you, I will see you in class Thursday for our first course exam. Have a good one.